A patient was almost discharged from the ED until one eye finding changed everything and they ended up in the OR. I'm Dr. Jasper Trotter, and after countless hours taking ophthalmology call, I'm going to share 3 clues that an eye patient cannot be discharged from the ED. And this you don't want to miss. Clue number 1, a bullous 360 subconjunctival hemorrhage, or SCH. A subconjunctival hemorrhage, or blood under the clear conjunctiva, is usually benign. Common causes include a Valsalva maneuver like coughing, straining, trauma, eye or eyelid surgery, or it's idiopathic. They're often asymptomatic and they go away on their own. So why would a subconjunctival hemorrhage keep a patient in the ED? So I'm going to show you 3 pictures. Pause the video and comment down below in the comment section which eye can't go home, A, B, or C. The answer is B. And if you didn't get it right, don't worry, just keep listening. This is one of those things that once you see it, you can't unsee it. All right, so let's focus on the hemorrhage pattern. In A and C, the hemorrhage is flat, but in B, it's elevated, bullous, and 360 degrees, and that difference matters. A 360 or near 360 bullous subconjunctival hemorrhage after a trauma is a red flag, because that degree of hemorrhage suggests that the globe sustained a significant force, and the blood may be hiding a scleral laceration or a globe rupture. So the key takeaway for clue number 1 is a 360 or near 360 bullous subconjunctival hemorrhage in a trauma is an open globe until proven otherwise. Don't manipulate the eye, defer the eye pressure check, place a protective eye shield over the injured eye, keep NPO, elevate the head to 45 degrees unless medically contraindicated, and consult ophthalmology immediately. Ruling out an open globe in these cases can be difficult, and that's where imaging can be very helpful in these cases when the exam is limited, specifically a CT orbits without contrast. Not a CT head. The cuts are generally too big and could miss pathology. When ordering a CT orbits, I generally recommend adding to the radiology order thin cuts 0.5 to 0.6 millimeters if possible, rule out an open globe and foreign body. A quick comment about image C. So this is a really good example of how a subconjunctival hemorrhage can look really dramatic and be completely benign. And here are some clues. Flat, no trauma, patient is completely asymptomatic, no pain, no vision changes, no double vision, and they may be on a blood thinner, which could have contributed to the diffuse bleeding. So here's the take-home point for clue number 1. It's not how red the eye looks, it's the combination of a subconjunctival hemorrhage with trauma, 360 distribution, and bullous elevation. Don't discharge that eye patient. Not yet, at least. Moving on to clue number 2, restricted eye movement in a trauma. Orbital fractures are common in facial trauma. In adults, an orbital fracture usually presents with visible signs of trauma. But in children, an orbital fracture can be more subtle. And that's because pediatric bones are more elastic. They can snap back into position after fracturing, creating a trapdoor effect which can trap an extraocular muscle, most commonly the inferior rectus, leading to restricted upgaze. So if this is the eye and this is the inferior rectus, which inserts into the white sclera, if the inferior rectus is hooked, it's trapped, it's stuck, when the eye is trying to look up, it also is stuck because the inferior rectus is basically getting pulled down. I don't know why, I guess the demonstration, I'm really into it. But if the inferior rectus muscle is entrapped, it can't freely move, it's restricted. So the eye has difficulty looking up because something is pulling it down, and that's the entrapped inferior rectus. A type of orbital fracture more common in the pediatric population is called the wide-eyed blowout fracture, because the eye may look normal, can look white and quiet, and the rest of the exam may look deceivingly benign. But the motility exam tells a different story. If a patient can't look up after a trauma, or there's some type of restricted eye movement, think muscle entrapment. And this is really important. An entrapped muscle may trigger the oculocardiac reflex. And this can lead to nausea, vomiting, or even bradycardia when the patient tries to look away from the fracture. So what to do? Get a non-contrast CT of the orbits with thin cuts. And here's a tip. Let's say there's concern for a possible orbital floor fracture. Scroll through the coronal and sagittal views to make sure you can completely see the entire inferior rectus muscle belly from origin to insertion. Look for tethering or abrupt contour changes at the fracture site, which could indicate entrapment. And don't rely on the report alone, especially if the motility exam is abnormal. So it's really important to do a careful motility eye exam on every orbital trauma patient. How to check for the oculocardiac reflex. Let's say you're seeing a case, imaging shows an orbital floor fracture, so the inferior rectus muscle is at risk for getting entrapped. I do want to quickly mention that the inferior rectus is not the only extraocular muscle that could get entrapped. If there's a medial wall fracture, the medial rectus is now at risk. So it depends on the location of the fracture site. So I do the motility exam. Let's say it's completely normal in both eyes. Ask the patient to hold gaze opposite the fracture for about 10 seconds. So in this case, I'm going to tell you to look at my finger and follow my finger. So we're going to look all the way up and we're going to hold it. So I'm going to say keep holding it, keep holding it, keep holding it. What I'm watching for is whether or not you're starting to get sick. I have my fingers on the patient's radial pulse. I'm looking at the monitor to see if the patient's becoming bradycardic. And after the 10 seconds, I'll ask the patient, how are you feeling? Or do you feel nauseous? If the patient is kind of cooling out, like, no, I feel fine, then that's a negative result. If a muscle is entrapped and if that triggers the oculocardiac reflex, symptoms can occur pretty quickly. And if there are any symptoms, stop immediately. If you suspect entrapment, urgent ophthalmology consultation is recommended. Children with true muscle entrapment often need surgical release of that trapped muscle within 24 to 48 hours to prevent ischemic damage. Another thing that can be helpful that I wanted to mention quickly is making sure in any orbital fracture patient to ask them if they're experiencing double vision. If they are, ask if the double vision goes away when covering one eye, because if it does, that means the double vision is present with both eyes open, which is binocular diplopia. And generally that's caused by a muscle issue or a nerve issue. When one eye is not able to look up, that's going to lead to double vision. So here's a scenario. A pediatric patient comes to your ED, baseball to the right eye. There's mild eyelid bruising, little swelling, but the eye looks white and quiet. It looks normal. And the CT orbits with thin cuts comes back normal as well. So time to discharge? Well, good thing you did a motility exam because the patient cannot look up with the right eye. And now there's plans for surgery. Wide-eyed blowout fractures are cryptic. They don't look dramatic, but the motility exam is often what reveals the emergency. And here's clue number 3, a relative afferent pupillary defect, or RAPD. An RAPD indicates optic nerve dysfunction, like in a traumatic optic neuropathy, or TON, or non-arteritic anterior ischemic optic neuropathy, NAION. See why we use acronyms in ophthalmology notes? Just saying. An RAPD can also indicate severe retinal pathology, like a large retinal detachment or RD. If there's a relative afferent pupillary defect, something is wrong with the afferent visual pathway. Normally, light travels down the optic nerve to the brain, like cars on an open highway, and both pupils constrict. In an RAPD, some of the lanes on the highway are shut down, and less signal gets through. So when you swing the light to the affected eye, the brain perceives less light than just a moment ago, when the lanes were completely open. It's as if the room just got darker. Instead of staying constricted, the pupils dilate. That relative dilation is the defect. If there's an RAPD, don't discharge that patient. Consult ophthalmology and consider imaging. But here's an important nuance. An RAPD can be old. If possible, check prior eye exams to see if it's been documented before and what the reasoning is, what caused the RAPD. If you don't have that documentation or doesn't seem clear, something seems off, assume that it's new and manage accordingly. An RAPD requires asymmetry between the eyes. There could be bilateral optic nerve edema without an RAPD if the optic nerve involvement is symmetrical. Some example conditions that can present with a new RAPD include traumatic optic neuropathy, or TON, non-arteritic ischemic optic neuropathy, NAION, a large retinal detachment, central retinal artery occlusion, or CRAO, intraorbital or intracranial compressive lesion, like a tumor, and optic neuritis. So to recap, 3 clues that you should not discharge a patient from the ED. Number 1, 360 or near 360 bullous subconjunctival hemorrhage. Number 2, a restricted eye movement in a trauma. Remember the cryptic wide-eyed blowout fracture. And number 3, a relative afferent pupillary defect, or RAPD. If you want me to do more videos like this, let me know that you like this video by literally clicking that like button, subscribe, and check out this video next.